Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Alicia Smalls is employed as a medical speech-language pathologist at Collage Rehabilitation Partners and Encompass Health Rehabilitation Hospital. She's a graduate research assistant at the University of South Carolina. She receives fellowship funding and is the recipient of the Norman J. Arnold Fellowship from the Arnold School of Public Health, University of South Carolina. Alicia receives an honorarium from Speech Therapy PD for her participation in this podcast. She has no relevant non-financial relationships to disclose. My financial disclosures are that I'm the owner and founder of BrainBridge Connect, LLC, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, I do receive financial compensation from Speech Therapy PD for the podcast and other educational webinars. I'm also an adjunct instructor at both James Madison University and Old Dominion University. My non-financial disclosure is that I am the secretary for the Communication Disorders Foundation of Virginia. Questions can be written in the chat or the Q&A and will be answered at the end of the presentation. And now, without further ado, we welcome our guest, Alicia Smalls, MPH, MA, CCC-SLP, CBIS, CDP, LSVT-C, who is a clinician scientist in training with a passion for translational neuroscience. Currently pursuing her PhD in exercise science with a focus on rehabilitation science and neuroscience at the University of South Carolina. Alicia's research bridges the gap between diagnosis and therapy by integrating advanced neuroimaging techniques, objective assessments, and subjective evaluations to inform and implement innovative therapeutic strategies. With extensive clinical experience spanning inpatient rehabilitation, outpatient care, and community-based therapy, Alicia specializes in treating individuals with traumatic brain injuries, strokes, and neurodegenerative disorders. Her work combines evidence-based interventions with patient-centered care to optimize recovery and enhance quality of life. Dedicated to advancing the field of translational neuroscience, Alicia aims to develop tools and therapies that improve diagnostic precision and treatment efficacy for individuals with brain injuries. As a board member of the Brain Injury Association of South Carolina, she also advocates for brain injury awareness, education, and policy initiatives. Her contributions to research and clinical practice have been recognized through honors such as the Norman J. Arnold Fellowship and the SCSHA Award for Outstanding Poster Presentation. Welcome, Alicia. I love your bio.
Thank you. Thank you so much for having me today.
Of course, of course. I'm so excited to finally see you, and hopefully we'll see each other in person in the next few months.
Yes.
But I really like to start just by asking people, because I'm a people person, as most of us who are SLPs are, and audiologists too. I just like to ask people how they got started, because I know your background was more in public health. How did you then translate over to the field of speech language pathology?
Hmm. Yeah, so my path was weird to say, to put it politely, I guess. I actually began as an exercise science major. So my undergrad is in exercise science. And I knew
Okay.
I wanted to work either in the medical setting with as a physician or either somewhere in the realm of therapy. And therapy won. uh, But in the process, I knew I wanted to conduct research. And I thought to myself, what better way to do that than to go after my master's in public health, kind of get like that statistical background under my belt and make me like a strong candidate. So I went and obtained my master's in public health, like about a year after I graduated with my bachelor's. And my emphasis was epidemiology. So I did a lot of surveillance data kind of stuff. But I knew that I didn't want to just sit there because I'm like a people person. I like to motivate people or like talk to people, encourage them to pursue their why. So I knew therapy would be my next path. And one day I was sitting down having a conversation with my son's speech therapist. And we were in the session and she looked at me. She's like, I think you'll be a good speech pathologist. And I was like, you think so? And she was like, yeah, I know so. And so like that following year after she told me that, I ended up applying to school at South Carolina State University. And I got accepted into their speech therapy program. And it's just been onward and upward ever since.
There you go. Well, and yeah, I'm a second career SLP, so I totally understand that my career path didn't start in the traditional fashion. So that's kind of why I was interested in knowing a little bit more about how you came into the world of therapy, because I think we all have, our unique stories and our reasons why we do what we do. And
Mhm.
neuroscience, has always fascinated me as well, which is why I'm so glad that we were able to connect and looking at this is an interesting topic for me because we see this so much in our patients, but a lot of people aren't talking about it. A lot of even
Right.
our physicians and neurologists don't really say this out loud. When we talk about autonomic dysregulation, we don't hear that terminology a lot within like the acute care hospital or the inpatient rehabilitation setting. We hear it more of, and I'll stop there and I'll ask you the question. How about that? Because I was going to say what we kind of hear it more, how it's termed differently. It's like
Mhm.
it's watered down a little bit, and I think that's why it's so
Okay.
important to get this conversation going. So can you tell us what autonomic dysregulation is?
Sure. So autonomic dysregulation basically is a dysfunction in the autonomic nervous system, which regulates our involuntary body functions such as our heart rate, our blood pressure, our digestion, our temperature regulation. So like after a brain injury occurs, this mechanism, the balance between the systems becomes imbalance. The two main branches of the autonomic nervous system is our sympathetic nervous system and our parasympathetic nervous system, which when a brain injury occurs, it leads to impairment and imbalance between those two systems. To understand autonomic dysregulation, it is important to understand those two main branches. So within our sympathetic nervous system, it's responsible for activating the body's fight or flight response. So this system increases our heart rate, elevates our blood pressure, dilates our pupils, redirects blood flow toward the muscles and away from like our digestive system. So within the brain injury, this system may become chronically overactive. So it's doing more than what it is typically supposed to do. So even in the absence of like an external threat, it's overactive. So this can cause our patients to experience persistent agitation, insomnia, out of the world high blood pressure, even panic-like symptoms. On the other hand, our parasympathetic nervous system, which is our rest and digest response, it lowers our heart rate, promotes digestion, helps the body like center and recover after that sympathetic, spike. So when functioning properly, you want the PNS to balance that sympathetic system. But within our TBI population, this doesn't seem to occur as rapidly or as adequately as it's supposed to. So this is what we call autonomic flexibility. It doesn't occur anymore. It's like significantly impaired. So what we see is that, for instance, if an individual remains like a heightened sympathetic state for an extended period of times, it leads to like chronic stress and inflammation. Like there, you'll see poor sleep quality and cognitive fatigue in them. So in like more severe patients, they'll have difficulty regulating their body temperature. Sometimes this may be or like have like a heart rate that's significantly high even at rest. And so like their resting heart rate can be maybe like 80 to 90 to 100, when before the brain injury, it was a resting heart rate would be probably like in the 60s or something like that. But you'll see like an elevated heart rate with just them sitting down. So sometimes this can be misattributed to anxiety or deconditioning when they are actually neurologically driven. So this dysregulation is especially common in our moderate to severe populations,
Mm-hmm.
but it can also occur in our mild TBI population, so our concussion population. It can occur there. So particularly if you see the symptoms prolonged within the population. So as clinicians, we have to be attuned to like the physical signs of the autonomic nervous system imbalance and recognize how they impact recovery, rehabilitation, tolerance, and like the patient's overall quality of life. So there is emerging research that supports that autonomic dysregulation following a TBI is not merely a symptom, but like a secondary driver of injury cascades. So there was a study by Khalid et al. And Hansen and Sheath that emphasized that there was excessive catecholamine release, which is especially norepinephrine, which leads to what we call like a storming effect. And
Mm-hmm.
this is known as, forgive me if I mispronounce this, paroxysmal sympathetic hyperactivity,
Mm-hmm.
PSH.
Yes.
This state can cause like a widespread effect of like cardiac dysfunction, renal stress, and even disruption in like our blood-brain barrier that contributes to long-term neuroinflammatory damage. Also, our ANS dysfunction is increasingly being implicated in what we call PPCS, persistent post-concussive symptoms. And so you'll see those presenting as chronic fatigue, cognitive decline, emotional instability, even in individuals with like mild TBI. So these symptoms may reflect like a persistent neuroinflammatory and neurodegenerative signaling process initiated by like a early autonomic instability, which in turn disrupts our cerebral perfusion and oxygen delivery to the our necessary regions of the brain that we need to recall information or do that higher level of cognitive thinking.
Yeah, and we see that a lot, if you've worked in acute care, we see that a lot in our patients. Initially, we see that temperature dysregulation. So you might see someone with a really high fever.
Right.
You also may see someone with a more of like a what's the word? I can't think of the word.
Can you describe it?
Yeah, when you're too cold, hypothermia. That's got to plug into my charger here, get my brain going. I've seen both. And
Mhm.
like you mentioned that, a lot of the mindset of this emotional dysregulation or agitation, irritability, a lot of times that's just contributed or attributed to the brain injury itself when it's actually a neurophysiological process that's happening that's causing this. It's not the patient's fault. It's not something that
Right.
they can control necessarily because it's part of their injury, but also part of the recovery process for these patients. And I think that's where people kind of we don't hear enough about that. I don't think in when we're in
Mhm.
school, we're trying to learn all the things and get the theories and pass the test and do all the stuff, but we have a hard time, I think, translating that into clinical practice when we get into the field, which is why sometimes I think people get really scared of some of the more and not to say that people that are in education don't need the medical piece as well, but more of a medical in your face day to day
Mhm.
space. A lot of people are intimidated by that for those reasons. They just don't understand that these occurrences aren't intentional. I've even
Right.
seen that with like other people that I work with on a multidisciplinary team. They're like, "Oh, well, they're super agitated. You don't want to go in there." And I'm like, "Well, they've got to learn
Mhm.
how to emotionally regulate and like it's a learn it over skill." It's trying to help them learn some strategies and some ways that they can maybe articulate it so we can know to help them.
Right.
Because no one wants a TBI. You don't volunteer. Hell yeah, I want to get hit by a motorcycle today. Thank you. That sounds fun. Or I want to, fall off of a building. That sounds great. Yeah, let's do that. So they certainly
Right.
don't want the injury to occur in and of itself, but you certainly don't want these symptoms either as a human, and you don't want to be made to feel like it's your fault. And I think that's sometimes where the multidisciplinary team can kind of fall short.
Right. You mentioned something and you said it's in our face in the medical setting. And like that struck a chord with me because I have hopped between medical and school at one time. And I noticed that the multidisciplinary team in the school setting weren't as attuned to this as we are in the medical setting to providing appropriate accommodation or implementing appropriate rest breaks or strategies for that population.
Hmm.
Because in that setting, it, like you say, you don't hear autonomic dysregulation. You hear, oh, this child has persistent headaches, or this child has ringing in the ears, this child has, visual deficits. But I think that when we can provide education within that realm, I think we can promote a better return to learn process for those students.
Hmm.
But I don't think we have a good carryover from that medical to that school piece. And it's significantly lacking. I think we need to kind of connect it so that
Yeah.
we have adequate recovery for this population.
Yeah, and I see that a lot in the late teen, high school, even in the college population of people that have had a lot of concussions or even a single concussion where they've got long-term, symptoms and things like that. There really not a lot of advocacy for that. It's get back to school, get back to work, let's go. You got to get back into it or you're going to lose your skill set when in all actuality, there has to be that balance of yes, we want to get
Right.
back, we want to be able to do it, but we have to do it in a way that is not going to promote an additional exposure event or injury and certainly not going to aggravate things like we know that sleep cycle's impaired. We know a lot of people have hyperacusis. They have photophobia.
Mhm.
We don't want to exacerbate those things because, like you said, it causes this whole storm of increased symptom presentation, meaning frequency, right? So
Right.
instead of having like this one event because you're tired, it now becomes sort of like the daily norm of your stress reaction to every little thing that happens. So,
Right. And then one symptom may present one day milder than the next day. So like
mhm.
it may be a heightened, your sensitivity to sound may not be as prevalent or present that initial day, but it may start to pick up the following days as you progress. So it's just interesting how like the symptom presentation presents. So I think we just need to hone back in to understanding like what autonomic dysregulation is so that we're capturing all the symptoms.
Yeah, and as you mentioned, and we kind of haven't delved into this in detail, but it does affect or impact cognitive recovery because when we think
Mhm.
about being fatigued in general because our sleep cycle's interrupted for anyone who's ever been a caregiver, ever, had a baby, you don't sleep for like, I don't know, 500 years or I remember reading something when I was when my daughter was a newborn and it said something like, well, expect 3 to 6 months before you get a full 8 hours of sleep. And I just sat on the bed crying because I was like, oh my God, I can't do this anymore. It's too much. But if you have a brain injury, right, and you're not sleeping, your body's not able to heal adequately. And then if you have this autonomic dysregulation in other areas, like you mentioned, the heart rate, our breathing pattern, our digestion, all of those things, those we know holistically impact cognitive recovery anyway. So if all of those pieces or some of those pieces are disjointed, how does that affect our cognitive recovery for these patients?
So, like you said, cognitive recovery depends on a stable physiological environment. So, autonomic dysregulation can severely compromise that stability. So like when the blood flow to the brain is inconsistent due to the autonomic imbalance, you'll have like higher level cognitive functions like attention, memory, executive function. So that will suffer significantly. These patients may experience difficulty focusing on maintaining attention. You'll see slower processing time, memory lapses, which are and like for an extended period of time. You're going to see persistent fatigue that limits our cognitive endurance. So you may have to cut your therapy session or implement massive amounts of rest break, depending on how severe they are. So as SLPs, we are uniquely positioned to support these patients. Our role includes evaluating these cognitive communicative disorders, particularly like attention, memory, and executive function, and integrating pacing strategies, which allows our patient to work within their physiological limits. We also want to educate the families about the link between the work that the patient is doing within their physiological limits. So like about how their cognitive performance may change over time, or, they're not going to be able to do this in this time frame anymore. They're going to need, assistance with this, or, put this in this manner so that they comprehend, what task or what sequence you want things done with them. And as SLPs, we naturally collaborate. You want us to collaborate with our neurologists, our cardiologists, our PTs, our OT, and our psychologists, because working in that interdisciplinary format helps with the overall time frame of recovery, like especially when we co-treat, because that's what I do a lot in my setting is I co-treat with other disciplines, because I know that if their patient gets 3 hours of treatment back to back, we're gonna have
I know. Yeah, and well, and often in patient rehab, we sometimes in some of our more severe TBI patients, we would have to split into 2 30 minutes that were broken up morning and afternoon, or try to do at least one session before PT got in there, because they're doing these physical tasks, which also is a cognitive task most of the time, learning wheelchair transfers, safely, ambulating, or just being able to be in like those parallel bars early on when people are, they might have other physical injuries too that prevent them from weight bearing, or they're limited in their weight bearing.
right.
So there's a lot of factors and a lot of pieces of information that we have to know. And it's a lot of times it is us coming to the table at team conference and saying, hey, I think we really need to schedule rest breaks. We need to split up our speech sessions. I need to see this patient in the morning before you come in and wear them out for the entirety of the day. And I think early on that sort of mindset of understanding those pieces from acute care onto inpatient rehab in particular, because in acute care sometimes we get in there and it's like, they want
Boom,
us to
boom,
be in
boom.
there for 30 minutes, and they can't do
Yeah.
30 minutes. Sometimes they can't even do 5 because they just can't.
Yes. I have come to learn that the best way to even start with them is if we co-treat. If I'm
Mhm.
co-treating with PT or OT, I know I'm gonna get something out of that session. So even while they're walking, I'm drilling them with some kind of cognitive task. Or like I'm asking
Mhm.
them, like they're going through their safety precautions with them, just like teach
Yeah.
back, a lot of that stuff. So like I lean on other disciplines to ensure that I get that the patient's also getting the benefit out of the treatment, because when you're doing dual tasks, it's more neural connections that occur. So
Mhm.
making sure that they also get that, and that I'm also getting the as much time as I can with them as possible. So that's why I love co-treating with other disciplines with this population, because I know I'm going to get the most benefit and most time when I'm with another discipline to get what I need functionally from that patient.
Yeah, and then for the patient too, you're teaching them that they can do some more simplistic tasks in a multitasking fashion because again, I didn't come out of school knowing about wheelchair transfers. I didn't have a TBI. So you've got and I'm just giving the same example because it's such a learned skill, and it's something that we worked on so much in both acute care and inpatient rehab. And we had
Mhm.
visual reminders. We would, like you mentioned, teach back. We would talk it through. Can OT get us in there? And while we're talking it through, have them execute the task while they're listing the task and things like that. They're just it seem like they should be so simple, but for these patients, they're really not that simple. It's a lot more
Right.
complicated and complex. So
Right.
I think we definitely have defined what our role should and could be, but then looking at also community reintegration, whether these
Mm-hmm.
patients are going on to another facility or if they're going home or if they're going home
Mm-hmm.
with a caregiver, it's the same thing. You mentioned caregiver education and family education, and I'm a huge proponent for both of those things because one of the things that always drives me nuts is when get a patient again, in either setting, acute care or inpatient, even in outpatient, when I worked in outpatient,
Mm-hmm.
how many times do you get a patient who's never heard the word executive function disorder or cognitive communication disorder? They've never received a diagnosis and they
Mm-hmm.
just thought that they were, and the patients have a huge variety of terms for it. But one guy had said, I just thought I was jacked up. I was going to be jacked up for the rest of my life. And I was like, that's a pretty perfect way of saying it, but it's also such a terrible place probably for that patient to be in, just to think that
Mm-hmm.
it's their own thing to own and they don't even know what it's called. And no one's taken the
Right.
time to explain it to them.
Bring it to them. Mm-hmm. I always ensure that I educate my patients because I know that they want, if once they leave me, they may not get further education because there aren't
Exactly.
many programs that go beyond the acute phase.
Mm-hmm.
Like people don't understand that a TBI is a chronic condition.
Mm-hmm.
You deal with it for the rest of your life. I went to I had the privilege of going to the BIAA conference, and listen to some of the survivors talk about how
Mm-hmm.
they have dealt with their traumatic brain injury over their lifespan. And I was a young lady who said that she executive function was her issue, and thought she wasn't going to be able to finish college, but she knew that she wanted to do it, and she knew that she needed to practice her executive functioning strategies every day because she knew that she wanted to become a professor. So it's like that kind of stuff that we need to be like aware of, like to educate them on how to carry that over into, their daily life and consistently use the strategies we teach them in things that they want to accomplish. I've had that with patients who wanted to go back to college, who are ready to go back to work,
Mm-hmm.
who wanted to start something new because they thought that they wouldn't be able to start anything new just because they had a TBI. And I'm like, no, you do have a TBI, but there are tools and strategies that we can teach you to get you where you need to go. So I, encourage them not to give up on themselves because we're not going to give up on them.
That's right. Yeah, I love that.
Uh,
Yeah, and so when we're thinking about assessments and tools and things that we need to be using that help us identify autonomic dysregulation, what are some suggestions or what are some things and in anything that we have, just so you all that are listening, Alicia has provided us with some show notes, so we'll have those posted in the next day or two. So you'll be able to see some of the things that we're about to talk about.
Okay. So as SLPs, we can't directly diagnose autonomic dysfunction. However, we have tools to like flag the symptoms.
Hmm.
So one is subjective assessment that we use in our concussion clinic is called the River Mead post-concussion symptoms. So it's just like a questionnaire, a scale that the patient goes through and marks to tell us like their symptomology. And the RBQ is considered a valid and reliable tool for assessing their patients who are even mild to severe. So we use it for like the whole range of TBI patients. The structure involves the RPQ evolves over time. It stabilizes two factors, the mood, cognitive, and the physiological symptoms, even after about 6 months post-injury. We have like a rash analysis that further supports the use of its unidimensional construct, making it appropriate for a TBI and a non-TBI patient. It can be administered face-to-face. You can send it via a questionnaire portal. You can prepare with other subjective measures. So you never want to just use any of these measures alone. You want to use a combination of measures. We also have the neurobehavioral symptom inventory, which captures a broad range of post-concussion symptoms, including mood, cognitive, and physiological concerns. You also want to rely on your observational measures as well. So like if you notice excessive sweating, breathlessness, dizziness, like a pallor disposition during cognitive tasks, you want to note those, jot those down. You want to collaborate with your PT and OT and monitor because they're the ones who monitor their heart rate. They're supposed to be monitoring their heart rate
And
during
blood
the
pressure.
session.
Yeah.
Yeah, during the session. And they're supposed to be relaying that message back to you as the SLP, like what's going on with them, so that you can ensure that you're tracking symptoms with them. Because once that heart rate revs up, that patient's going to have headaches, which is going to affect your session. So you need this information. So just some session tracking, documenting when and during which activity that the symptoms began. I always, at the beginning of my session, ask them of their RPE, the rate of perceived exertion. So like on a scale of 0 to 10, where are you at the beginning of my session? And then I always have like a time marker in the session, like maybe like 10 or 15 minutes in, ask them their RPE, and then ask them like if I know that they have headaches, what's your headache at right now? So then I know how to tailor what I'm presenting to them, or whether I need to implement a rest break, or we need to take a break from a certain task, or I need to like change what I'm presenting to them because it may be causing them more distress than good. So yeah, as SLPs, we can do that. We can flag the symptoms, we can document it, we can relay that information, because the more that we document that these symptoms are presenting themselves, the more that the physicians have to say, okay, we need to examine what medications this patient's on. This doesn't seem to be helping. So document everything as far as their symptoms are concerned.
Yeah, and you mentioned a good one too, because I was just sitting here thinking about as many times as I worked with PTs, and they would say to the doctor, because we always word it in the way of suggested, right? A lot of the PTs would say, I think this patient might have orthostatic hypertension or orthostatic hypotension, where they get up and suddenly their blood pressure is elevated, or the other case, this blood pressure just drops and they have to get them back in the bed. So yeah, I learned from some really good neuro PTs early on in my career on how to word things so that I didn't sound like I was trying to tell the doctor what to do, but like based on the symptoms of da da da, we think that maybe this is what's happening. And then, I worked with some
Right.
really great doctors in inpatient rehab. And so most of the time they always treated us like we were part of the team. It wasn't a traditional like hierarchy of
Right.
I'm higher in the food chain than you are because I'm the physician. And so I'm very grateful for that experience because it taught me a lot, not only with how to collaborate, but like to learn from other people who had more experience and had been in the field longer or had seen different cases based on maybe they were in a bigger hospital prior to and just had more exposure. So it's always a great space to be able to learn from our teammates in that regard. But yeah, that's another one I think that really impacts our session, because if your blood pressure drops suddenly or increases suddenly, you mentioned increasing can
Mhm.
cause the headache. If it decreases and they might get dizzy, they might pass out.
Yes.
I've seen that happen before too. They
I've
get
seen it
up,
happen.
yeah, and like
Yeah.
you mentioned the
Yeah.
pallor, like all the color drains from their face
Mhm.
and they're like ghostly white or kind of gray, yeah, you want to
Yes.
make sure you're communicating all of those things and making sure that in that case you do have someone with you that's co-treating and knows what to do, especially
Mhm.
early on. For, again, we're not exposed to this unless you get to work in a TBI center or a heavy neuro clinic when you're a student or even a CF. So it's a lot of, as I call, on the job training. We get a lot of that.
That's what I got when I was a CF, because I got my first major TBI patient when I was a CF. And
Same.
I was like, that put me into gear really fast.
Hmm.
Really fast. I knew I needed
Yeah, and
to
I
find all the information I could.
yeah, I always say I love a good TBI. That I'm like, sorry, that sounds really sick, but like, it sounds like I got something wrong with me. But I just I find it fascinating, and and I said this probably a few podcasts ago, but when I got my CBIS, it was such a learning experience too, because people don't realize, at least for me, the amount of studying that goes into taking that exam. That exam is not easy. And
Not.
I spent probably 3 or 4 months prepping. Um,
Mhm.
and then I've had mine for over 10 years, so it's a little bit different now as far as like access to the study guides and stuff. We were not, you had to either buy one or know someone who had one. And I got lucky,
Ooh.
I knew someone who had one. But it's still like I have my own training guide that was a compilation of like research articles and stuff that I tried to do to help myself. And it's a 2-inch
Big.
binder full of stuff, from research to facts and statistics and the neuroanatomy that you need to know,
Right.
and the neurophysiology part that you need to
Physiology.
know. Yeah,
I,
it's a lot.
yeah. I just recently transitioned, so I'm now a trainer.
Oh, cool.
Yeah. So I can concur. It's still intense, even with the amount of CEUs and information that you need to acquire and write about, because they want you to stay current and stay up to date on everything.
Hmm.
So yes, I have a thick binder as well.
Yeah, and I even thought about doing the advanced practice one, but maybe someday I'll get there before I'm too old to be able to study and do it myself. But I think, this is a really good space to probably talk about maybe a case study and how you've seen addressing this being impactful on a patient's recovery, because we know all of these pieces and parts. We've talked about it in a treatment standpoint from more of a regulated treatment kind of space versus the overall recovery for the patient. What does that look like for these patients?
Uh, I've had some interesting cases. So I work in a home and community setting also, so I get to reintegrate them back into the community. So that's like my favorite part. And one of the cases that I had was a fireman, and he sustained his TBI from putting out a fire and the wall collapsing on him.
Oh,
Yeah. He was super young. He was 20, 23 years old. And during case history, I found out that he had played football in college. So I don't think the team knew this history. I think I was the only one that collected that history, and then I passed it on along. He was very high functioning, but during like the reintegration into the community, he had complaints of constant severe headaches. He had complaints of auditory hallucinations that would be occurring. Uh-huh. He had ringing in his ears, fluctuating blood pressure. Then one day he was having a session with the OT and he was telling us about something that occurred with him. He was telling us that he was riding in a car with his family member, and then all of a sudden he couldn't speak or communicate or engage in a conversation with the family member. And the symptoms that he was telling us sound like stroke symptoms. like a transient ischemic attack. He told us that after he came to, that he fell asleep and felt and stayed asleep for 30 minutes to an hour, and he felt extremely exhausted. So we had to like educate him on how even after a TBI, because the system is in autonomic dysregulation, patients can potentially have strokes or potentially have seizures. So we sat down and went through the whole Be Fast protocol with him and his family, so that he can ensure that he got to the ER quickly to be assessed for whether or not he had a stroke or a seizure. As another thing that he experienced was like imbalance that the OT was still working with. So he had vestibular things going on. I saw like some episodes of physiological distress during this. So what I found out was that the PT wasn't giving him adequate rest breaks. So I during team conference, I kind of brought up what autonomic dysregulation was to them. And some of the team didn't understand what autonomic dysregulation was, so I educated them on it. And I will point out symptoms to them that the patient said that they had in their sessions with them. And I said, he's telling y'all outright that he's in distress and that we need to basically come at this a different way. So I had to advocate for a referral to audiologists, advocate for a referral back to his cardiologist and neurologist. So that they can investigate the underlying causes of what was causing him to have these episodes. And that process, I took on more so an educational role for our team, because I don't think they were fully aware of what it was and what he was feeling or what he was going through. And with me doing this, or like providing them that piece, it allowed for us to coordinate and to push his recovery in a better direction than where it was going. Because prior to us understanding that he had autonomic dysregulation, he was going to the hospital for like certain things that he, wasn't sure what it was or what was going on with him. So over time, the patient did improve. He increased his cognitive endurance during therapy. He had better sustained attention, memory function, and upon discharge, he applied to get his master's in public health, and he went to divinity school as well. So,
Oh, wow. That's amazing.
yeah.
Well, and I think again, when you were thinking about our role as, educators, not only to our patients, but also to our team, like you said, because not everybody comes in with the same education. Not everybody comes in with the same clinical experience as far as where did they do their practicums, what setting were they in. Maybe they didn't have anything, they've never seen this before. And then, you touched on vestibular. One of the coolest PTs I ever worked with is a vestibular specialist, and this was more an outpatient, but it was so cool because she loves to teach, and she actually teaches at the same university I do now in the PT school there. But even as colleagues, she just loved to share her experience, and to watch her work and learn from that was a really cool experience, because you see how the cognitive load is increased during physical tasks and how it
Mhm.
affects the endurance of not only the cognitive endurance, but the physical endurance. And again, we have to stop thinking about this as a one size fits all, because you mentioned early on the symptoms can vary from day to day or hour to hour. But what we also see is that not all the symptoms happen at the same time or co occur.
Exactly.
You also mentioned seizures. I'm actually working on a project right now about TBI and post-traumatic epilepsy, because
Mhm.
that's another piece that people think, if you didn't have a seizure immediately after your TBI, you might not ever have one. But in fact, that we know now that that's not true based on research, and
Right.
kind of knowing what that looks like, because I'm sure most people have heard the term silent seizure. And that's typically a focal seizure. The patients often don't look like they're having what we consider a seizure, right? They're kind of just staring into space. They're able sometimes to talk to you while they're having it. It's more mild a lot in a lot of cases. And but again, it's that symptom tracking that having the patients have that safe space to tell us what's happening. Because again, once they go home or they go to a different setting, another good point was they're going to the hospital for these symptoms, right? They're incurring these medical bills of going to these ER visits. That's when we start looking at things like uh, social determinants of health when it comes to literacy, when it comes to access to care, insurance coverage. You know, we, this is terrible, but it's true in healthcare. We get what we call the repeat offenders. They come through the
Yes.
emergency room all the time and they're like, you get this call and it's like, well, Mr. So and so's here again and they're just going to discharge him home, but no one's telling him this is what's happening. Follow up with your PCP before you come back here and incur this large bill or this huge copay, or you haven't met your deductible and you're paying out of pocket. Or in some cases like our Medicaid patients, they may not have, I don't even know, that's a whole other topic. Honestly, they may not have a PCP that's been assigned to them if they're a new patient with a TBI, or they had a new stroke. They may not have gone through the system for
Right.
disability or anything. They may not even be eligible. And so that's a whole other piece of this that I think the general public and even people that work in healthcare who don't know about this piece of the recovery process, that they just make assumptions. They're like,
Mhm.
oh, here he is again. Have you seen
Right.
that in your practice as well?
Yes, I've seen that, and I'm like, oh, such and such is back again. And I'm just like, because we didn't. I'm thinking in my head because we didn't address all of this the first time they were here. Like if we were on board or on one accord, such and such may have not been back here again. Would have been better equipped to handle the symptoms or known what like physician to turn to or ask questions about, or maybe the physician would have known whether or not to adjust the medication, or let them know that this may not be appropriate for you at this time, or working out may not be appropriate for you at this time, or this intensity of workout may not be good for you at this time. Because like when you're in autonomic dysregulation and I'm an advocate for working out with this, however, within regulation.
Mm-hmm.
Because if you are doing max workouts with this, you can trigger a seizure, you can trigger a stroke.
Mm-hmm.
So it's just working out within reason, doing what daily activities within reason and with good monitoring until your symptoms begin to subside. So like I see a lot of SLPs advocating for exercise with cognition, or like, exercise your brain. I'm like, yes, we want to do that, but within reason. When you understand autonomic dysregulation and the patient understands it, great. We should do that.
Yeah, because then you're looking again holistically. What does this patient need so that we
Right.
can try to minimize symptoms without aggravating and like you mentioned earlier, putting them into a storm, because if you've worked with the TBI population, we've all seen it. Or at least maybe some of you have seen it and didn't know what it was called, or maybe you weren't aware that we should be symptom tracking. And again, I think that's why this is so helpful, because I know with you mentioned, your early TBI patient. My first TBI patient, everybody was afraid of him, and it was a perfect storm of exactly what we talked about. He was having, initially he had high fevers, and so he was kind of, they were putting him on bed rest a lot, but he also had bilateral lower extremity fractures, and he was
Mm,
non-weight bearing, and he was
impulsive.
definitely like fight or flight mode, impulsive.
Yep.
They termed him aggressive, but it was more like he was so dysregulated that he didn't, they said you can't walk it. He's like, well, I can. And they're like, no,
Yeah.
you're non-weight bearing. And he was like, but I'm fine. And they're like, you broke both your legs. He's like, no, I didn't. He's looking at you like you're crazy. So
Right.
he would, walk down the hallway with his wheelchair on his back and just stuff like that. And it was just, I had never seen anything like that. So it was such a good learning experience for me to try to work with the team and really advance my clinical skill set as well, but to look at, okay, long term, he's going to leave this
Mhm.
inpatient rehab facility. He's young, he's a parent, he was working. What does he need? Not
Right.
just what does he need as far as like he needs to heal his fracture so he can walk, but what does he need to be able to do on a day-to-day basis? Is he able to manage his own finances? Is he able
Mhm.
to put an appointment in a calendar? And
Right.
again, I think people get hung up on these like worksheet based therapies and they forget that all these things that we do on the day-to-day basis, using your cell phone as AAC.
Mm-hmm.
It is. You're
It
using your
is.
calendar. You're putting voice memos in there, or you're doing speech to text when hopefully you're not doing that when you're driving, but I know people that do it. And with me, I can't really speech to text very well because, uh, for whatever reason, my phone thinks that I speak a foreign language when I'm
Um,
speaking English into my phone, but what comes out in the text is like, no, there's like nonsense words
or
all kinds of stuff. So, but we're thinking about all these tools that we use every single
Mhm.
day. And I've even seen this with family members before who are like, well, I don't want them to rely on the calendar. I don't want them to rely on the
Mm,
visual schedule. And I'm like, but you do that. You do that and you don't have a TBI,
right.
right?
Right. I think it's like they set a separate expectation for them because they like, oh, you should be able to do this because you were able to do this before, not realizing that this person that is in front of you now is a totally different person.
Mm-hmm.
They have a TBI, they're totally different. They're going to learn different. They're going to do things different. And I think it's like even educating the family on accepting the new person that is present in front of them, like
Mm-hmm.
making them understand, like, yes, dad was sharp as a tack before and could calculate those finances, but right now, dad's gonna need that calculator so that he can check behind himself to make sure that he's not overspending or he's not overdrafting his account. So I
Yeah.
think it's just like kind of helping them reframe their mindset on who they are now. Because a lot of our patients struggle with that. Once they have the TBI, they're like, I can't do this anymore. And I think it's hard for them to even be around family who don't
Mm-hmm.
understand that they're not who they used, who they were before. And I always tell my patients, it's okay not to be that. I say it's okay to be a new person. The new you is good too, just as
Mm-hmm.
good as the old you. So, don't worry, like let's leave that person behind. Your new perfect person with a TBI. That's your superpower. Like just go with it, roll with it. You have a team to support you. We're gonna be here to help you along the way and encourage you as much as we can and give you all the tools that you need to make it through.
Yeah. And I think that's two really important things is use your tools. And then also, when I explain neuroplasticity to the patient and to the family or whatever the caregiver is, because sometimes it's not family, is saying, if you're going to go to the grocery store and you get to the end of your neighborhood and the road's closed because there was a storm or a pothole or it's flooded or whatever, you can
Mhm.
likely still get to the store. You might have to take a different route, which might take you longer. And that's sort of what we're doing now is we're relearning these skills and you're going to be able to get to the end result, but it might take you longer and you might have to take a different route than what you would have done
Right.
before. And I
And
think
that's just fine.
yeah, and that's
Yes.
okay because still the end result will be you could still get to the place that you're going. We just have to do it differently now. And that's perfectly fine. But as we kind of start to wrap up, do you have another case study you'd like to share with us?
Let's see, I've had this case study. He it was like a young adult patient. He had a mild TBI and he had what we call cognitive fog. He still has severe headaches as well, but he fatigued real fast. So in therapy sessions, He had flushed skin, sweating, shallow breathing, like was visibly anxious. Even doing like a low effort task, he was visibly anxious. So with our multidisciplinary team collaboration, we facilitated a referral to neurology where he was diagnosed with POTS,
Mm-hmm.
postural orthostatic tachycardic syndrome. So a targeted treatment plan was implemented for him, which included medication management, hydration protocols, compression garments, and structured graded exercise regimen. So like with that referral and implementation of those methods helped us hone in on the appropriate way to target therapy with him, and he was able to recover successfully as well. I believe he got his TBI from a car accident. So I'm always amazed at the mechanism of injury because people
Mm-hmm.
think that all TBIs are the same or like so they're so different the way they present themselves. And I did like a research recently that compared sport related TBI to non-sport related TBIs. And what we saw was that within the non-sport related TBIs, they presented with more severe symptomologies of sleep disturbances and cognitive fatigue compared to the sport, which we thought, sport was going to present with more things. But if you look at it, there's a different impacts that comes when you're in a motor vehicle. You have
Mm-hmm.
that you have that outside, you have that direct impact, you have the centripetal force, but within sports, you have a direct head-on impact. Like whatever hit you get, that whatever pop you get is directly, in that direction. While a car accident, you could receive it from multiple directions. So it was like pretty interesting to see how different they were within their recovery. Even though they were both considered mild, the mechanism of injury really matters in the way they recover and in the way we implement strategies for each of the populations.
Yeah, and we see a lot of the coup contra coup in motor vehicle crashes. You can see that in sports too because of depends on where they get hit and, the impact. Oh,
Right.
the force and things like that, but it's always I'm the same way. I'm always interested, like the young man that was my first TBI patient. He was making a right, or he wasn't doing anything. He was in the right-hand lane, and an SUV decided to turn into a 7-Eleven convenience store from the left-hand lane and hit his motorcycle and then ran over him. So he had multiple hits in that. And then, with we see these sometimes, oh gosh, I love sports, but sometimes I'm watching sports and then I'm like, you see a hit, especially with
Hmm.
football, sometimes also with soccer, you see the person go down and you're just like, oh, no. And I freak out every time. But yeah, it's just always astounding to see the multiple impacts in multiple areas of the brain. So
Hmm.
you might see some temporal parietal frontal right side involvement, and then in other patients they have more of an occipital based deficit where, and this is where I get into it with students when I teach the adult communication and language disorders course, is that they can't wrap their head around the fact that even if someone had an occipital primary impact,
Hmm.
they may still have some issues because of blood flow, poor oxygenation to the brain. Then they may have some deficits in executive function disorder because they got hit in the back of the head and the front of their head also had a response.
So part I'm gonna tiptoe a little bit. Part of my research that I'm doing now is, how there's a pathway through the pons, the
Mhm.
medulla. So it's a pathway
Yeah.
that goes through there that comes through the occipital lobe, but cuts across to the supratemporal gyrus and the supramarginal gyrus, and then connects to our inferior frontal gyrus and prefrontal cortex. So
Mm-hmm.
even though it's going to just, oh, that was the hit back there. You got to understand the connection between those regions. And because
Mm-hmm.
of that SMG, STG, and you see that the patient is not recalling auditory information, it's because of that connection from here to here. So I
Exactly.
thought,
Yeah.
yeah. So
I always say we're connected,
it's yeah,
anterior to
here
posterior,
posterior,
superior to yeah, all the
inferior.
big words. And thank you. And then also, bidirectionally, right to left, and
Yes,
your brain was connected all that way. So if any one piece of that is impacted, we may see something that we weren't necessarily expecting to
right,
see. If you're solely looking at, oh, the major hit was in the occipital lobe, or the major hit was in the left temporal,
right. We in
whatever.
neuroscience, we don't even operate in regions. We operate in nodes of connection.
That's right.
Yes.
Yeah. Oh, that's a great, oh my gosh, that's such a great place to end this on. Nodes of connection. I like
Connection.
that. Well, I don't see, other than some technical questions, I don't see any questions in the chat.
Okay.
But I did want to just say thank you so much, Alicia. This has been a long time in the works, and so I appreciate you being willing to take time out of your summer, even though I know you're still a student, but you're doing some pretty cool research and you're a very busy person. So I just really appreciate you taking the time and sharing all your, well, not all your knowledge, some of your knowledge, because I know you have a lot more knowledge in there. But I just appreciate it so much. Again, Alicia, thank you so much for being with us, and we look forward to seeing you again.
Thank you so much for having me.
Of course.